Good evening, everyone. This is our monthly DFW area Reach Families parent training meeting. And due to COVID, we are meeting on Zoom, and it's worked out really well because families from all other areas can join us. And our guest today is Rebecca Dana. She is a master's level trained certified speech and language pathologist. She has a clinic here in Frisco, and it's a suburb of DFW. And she Walk Easy, Talk Easy is the name of her clinic. And we have several of our families from our community whose kids attend that clinic, and she works with them. And she has a very strong reputation in the Dallas-Fort Worth area. She works with a lot of families. She's certified in several things. She will tell us a little bit about all the things that she's certified in. But today she's going to teach us about prompt therapy. And I have my son used prompt therapy when he was younger, and it has helped him quite a bit. And I really want us to learn more about it. We will have her presentation, and then after that, we'll have some time. We'll entertain about 15 questions. If you have questions, please put them on the chat, or if you all know my cell phone number, you can text it to me. But we end up getting a lot of questions at the end. We can do about 10 to 15 questions, depending on when she finishes. So if you have a question, send it to us immediately. So Becca, I'm going to let you tell us a little bit about yourself and do your presentation, and appreciate you so much for coming and presenting for us on a Saturday afternoon when you're working Monday to Friday. I know those Saturdays are precious, but we appreciate you taking the time to teach us about prompt therapy.
Well, thank you so much to everybody. Thank you for having me. It's been a while since I've presented, so it's really kind of funny for me, but I hope this will go well. So I'm going to share my screen with you. And well, just thank you and welcome everybody. I just wanted to introduce myself. I'm a speech pathologist. If you have questions, I have my email address there. So if I can't get to your question today, just shoot me an email and I'd be happy to answer any questions that you might have, okay? I have so much information to share with you today, so I'm just going to go ahead and get started. Okay, so this is me. I'm pretty much a nerdy person. Those are a lot of classes that I've taken. But aside from being a nerdy person, I've got a great husband who supports me and entertains a little bit my crazy ideas. I love to dress for Halloween, and I love my job. We've got 2 boys, and we've got several dogs to add to the mix. So if you're therapists, please, mark in the chat, let me know. These are just some of the trainings that I've had, and I'd be happy to lead you to other areas if you're interested in other things. And as I go through this presentation, I can't help but merge all the things that I've learned and put it in the prompt conceptual framework. Sorry. Okay, so what is prompt? So prompt is basically a workout for your muscles, for your face. So as speech therapists, we really work on a smaller level. And what we do is we utilize our hands to be able to help us move the musculature of our clients, to help them be able to put their speech sounds together for speech production. So in the prompt conceptual framework, we have 3 global domains that we really look at. So I'm going to talk about all 3, and I do have videos for you to kind of help explain some of these different things that we see. Okay. So the first part of the conceptual framework is called the cognitive linguistic domain. And there are several different areas that we look at in this area. What we're really looking at is perception, and I have vocabulary and some definitions for you, so you don't have to try and write all of this down. You can take a snapshot if you'd like. But perception really is having to do with the awareness level. When I'm working with kids, especially if these kids have concomitant issues, meaning that cognition might be a little bit of an issue for them. They may or may not be aware of their space, aware of their environment, aware of their body. And so perception is a big starting point for a lot of our families. And along with perception, we have sensation. So because we use our hands, I'm gonna just kind of show you. I've got some gloves here because I always wear gloves, especially with COVID. It's super fun. But I'm just going to kind of show you a little bit. When I use prompt is something that requires tactile cues whenever we start looking at the expressive language. And so I just kind of want to show you, you see this right here? This is a very big portion of skin that fits nicely on the face right here. So if I want to provide some jaw stability, I'm going to nestle the chin right here in the web of my hand right here. Okay, so when we're looking at awareness, we have to know that there's something there. And sensation is, how much of a cue do I need to give? And then can I differentiate that cue from a light cue or a heavy cue or a firm cue? It just depends on what's happening with the musculature as to how firm a hand position I need to have on the child's face to help them move their musculature. And then recognizing when to move, and then putting all of those different components together to develop a concept formation of movement for speech production. See here. So along with this cognitive linguistic domain, we really just want to actually look at what that looks like, because most of the time when I work with families, I often get asked questions like, how do I know if my child is ready? How do I know if this is the right kind of therapy for my child? So this video, I've got great parents, so I'm very thankful that they allow me to share this with you. This is like a live session, and it shows you the beginnings of when we're getting started with therapy. And over on the left, I've just kind of given some bullet points of things to think about, and I'll go through that. So let me press play here for you so you can kind of see what therapy starts to look like. Just have to watch and see. So look, I'm going to see if she'll let me get into her now. So I'm going to have you wear some gloves so that she can see that you're going to wear some, and that I'm going to wear some, and that that's not scary. Our gloves usually have a little bit of a flavor to them. Okay. So they're not ordinary, and this one may not have a flavor, but most of them do. So we have grape flavor and bubblegum flavor and cherry flavor. And then some of them head, shoulder, knees and toes, knees and toes. Okay. Yes. So
Yeah. That's
I
okay.
always sit in front of you again.
Yeah, that's okay.
I'm
So
not
I'm going to actually, I'm going to have her sit against me.
like this.
Come here, see if she'll sit against me. And then what I'm going to do is I'm going to actually have you straddle my legs for a minute.
Like how?
Like this way.
Like this?
Oh, what I'm going to do is I'm going to work your body and you're going to work her body. Okay, so she's going to stretch you. I'm going to go 1, 2, 3, and then you're going to actually pull hers out. And you're going to go 1, 2, 3, and then I'm going to go 1, 2, 3. Your turn.
And it's 1, 2, 3.
And if she lets me get to the face, I'm going to go, you, smile, are cute. Okay.
How is it?
Okay, so down. You, smile, are, kiss. Cute. Yes. Okay, so you see how everyone had like 3, a count of 3? Okay, so we're gonna do it again.
Okay.
Okay, so we're gonna do a 3, a count 3. Okay, so 3 cycles. We're gonna go 1, 2, 3.
1, 2, 3.
1, 2, 3. And I want you to keep a note of how firm my touch is, okay?
2, 3.
Good, okay. You are cute.
Okay, my turn. You are cute.
Perfect. 1,
Sit down.
2, 3.
1, 2, 3.
1, 2, 3.
1, 2, 3.
You are cute.
You are cute.
Yeah.
So in this particular video, I just kind of wanted to show you how to begin the process of interaction. And I don't go straight for the face. I often will work from the body up to the face. And what this area does is it teaches routines and boundaries. So I'm always counting. Okay, and then that helps the child to know the expectations. Okay, and then as we move forward, you'll see a little bit more of what that looks like. Oops, let's go to the next one. For the progression of talking. So the next thing I want to talk about is skeletal structure. So Prompt does a really great job of organizing everything hierarchically, which follows the developmental growth curve for kids in their acquisition of language and speech production. And one of the foundational things that we look at is skeletal structure. And skeletal structure is your muscles. It's looking at your bones. It's all of that fiber. It's the way in which your brain registers information and then responds to the feedback that it receives from the environment. So in that previous video, I was talking about touch. Because we touch the face, you have to get familiar with touching the body. And I often give deep input to the body because deep input is calming, where light touch can be alerting. And light touch is as if when you would be walking outside and then all of a sudden you might have a mosquito land on you and you can hear it and it's light, and then all of a sudden your alert system comes on and you're slapping at it, swatting it away and things like that. So we always want to use a firmer touch than a light touch. Okay. In this skeletal structure, what is really amazing to me is to be able to watch children when they eat, because then they'll show us what that musculature looks like and the way in which it's performing. And then it tells me a lot about what's functioning and what's not functioning and where therapy should begin. In this particular video, I have blocks all over the floor and picking up the blocks in the background. So I know it's a little bit distracting, but watch the face as she is eating her applesauce. Okay. And I'm just watching. So she's showing me all of her skills.
Appatosh, let me see.
Look at Miss Shannon.
Oh, show her your applesauce.
Can you get another bite and show Miss Shannon?
There's your jaw jet right there.
So what's a jaw?
Jutting forward. Which means she's out of alignment when she's trying to swallow, which means her tongue is going to be out of alignment automatically because she's out of alignment. Okay.
So a jaw jut is movement, and it's a movement where the jaw moves forward, and that's what jut means. So you have this position of your jaw, and then it moves forward. And when it moves forward, then the tongue also moves forward, which means anything and everything that the tongue makes contact with, it's an approximation, which is a compensatory strategy. So over time, those compensatory strategies will break down. So what we want to do is we want to refine those compensatory strategies to where they are more appropriate and the child can build a stronger base. Okay, so we want to remove those. Okay, the last domain is the social emotional domain. The social emotional domain really has to do with the way in which people interact. It's the functional language. So the way in which you exchange your ideas, the way those ideas are perceived from another person, and then they're able to process that information and either agree with you or disagree with you. So it's early communication with nonverbals as well as with verbal individuals. What I find amazing in this particular moment in time is that I can always go into the home and work with a parent and a child, and you as parents are amazing. You know your children the best, okay? Me as an outsider, someone unfamiliar with your child when I first start with you is a disadvantage for me, so I have to build rapport. And the best way to build rapport is to engage in interactions that involve people games. Okay, and people games are games that involve, you know, body-based movements such as like row, row, row your boat, and you can have your child with you and you're rocking back and forth and you're singing. Singing is a right-brained activity, so it helps to alleviate the left side, which is the logic, the language side. And it helps the child feel more comfortable in the routines that we're building. And I can never, ever replace a parent, ever. You parents, you're the cherry on top, okay? And sometimes we have children that are like really, really, really close to their parents. And sometimes we have to make a little space for other people. Sometimes we have children that are more closer to mom, sometimes more closer to dad, and they're constantly sitting on their parent or hanging on their parent. And in order to have any kind of interaction, then I need them to interact with me. So that's what I mean by creating a little bit of space so that we can have some reciprocity and build trust and rapport. and of course, allow them to be able to come into contact with other people and have a relationship with other people as well. Okay. Here is a good example of body-based communication. In this particular instance, this little guy is already struggling a great deal just to stand up, to walk. His tone is low. So to get him to a place where he's talking and he's coordinating his muscles of his tummy to get that air, the flow of that air past the vocal folds to allow them to vibrate, for sound to come through, and then the shaping of the mouth with the muscles, the jaw, the lips, the tongue, is a lot of work for him. So I just want to show you in this particular video how to take it a little bit slower because he's already working really, really hard, and we just honor that. Okay. So here we go.
Up, 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 up. Up, 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 up. Here I am. Here I am. Mhm. Oh, what did you want? What do you want? Head. Okay, ready? Watch your jaw. Open. Head. 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 Should I sing? Head. Head. Shoulders, knees and toes. Knees and toes. Head, shoulders, knees and toes, knees and toes. Eyes, eyes and ears and mouth, mouth and nose. Head, shoulders, knees and toes, knees and toes.
This is such a great little guy. In the prompt hierarchy, we haven't talked about all the different prompts that are involved. One of the first prompts that we look at is the sound, and we give a visual cue to be able to coordinate the muscle groups of the diaphragm to pull that air up and into the oral cavity. So you'll see me go in this particular video. And then I am giving him a parameter prompt. So I was talking about this web right here. So you can give a parameter prompt like this. And if you place your hands on a child's face or an adult's face, you have to have a counterbalance. Okay, so you're going to take your other hand. Okay, so I'm going to go this way. And then you have to be able to support the head, because if you're applying some firm pressure this direction, you have to have a counter here. Okay, so this back and forth movement actually works a lot of spine alignment, and then you can actually get that diaphragm engaged instead of having posture that's collapsed. And oftentimes I'll use child-friendly words like, oh, you're giving me a turtle, because they're hunched over, or if you're going to give me a giraffe neck, so then all of a sudden they're sitting up and we've got good access to that air in the tummy. Okay, so in this particular instance, I was very, very slow and very rhythmic to help him be able to organize his thought process and the information that he's receiving. I think I have a little friend that's drawing. Okay, let me see. Oh, and we talked about right brain. So right brain is that singing, so it alleviates some of that language. Okay, and then active engagement versus passive engagement. Active engagement has to do with your perception. You feel it and then you move, you initiate. Okay. When you do not feel it, you do not initiate. So that's considered passive. A lot of times what we do is we work from that passive to the active, and that is where the therapy begins to help brighten the awareness of what we're looking for when we are starting to engage the musculature a little bit more. Let me see. Okay, sorry. There we go. So the next thing that I'm going to talk a little bit about is balancing the conceptual needs. So remember, we've got our cognitive linguistic area. And just to summarize, the cognitive linguistic area is your receptive language. Okay. And then the physical sensory is your structure, your muscles, and your verbal production. The social emotional component is that use, that functional use of pulling that cognitive linguistic together and that physical sensory together so that we can get communication happening. If we have a lot of children in ABA, ABA is wonderful. They are very good at giving a lot of vocabulary. And children are very good at labeling, but labeling will not help you put two words together to be able to use it in a back and forth communication if you're only using one word. So our whole concept is to put a lot of these motor plans together so that we can create regular language. Okay. So as you're thinking about your own child and you're thinking about your own child's skills, okay, you may be thinking, well, where do I begin? What if my child doesn't like to be touched? Okay. Then what do I do? And we're looking at how do we build rapport? You know, that back and forth communication, making that space for other people to come in to be play partners. And then modeling, we'll give visual models. Okay. So this is a sweet little guy. He loves water. How many of your children love water? I love water too. Okay. And he's still trying to decide if I'm a safe person. So in this particular instance, he is very much in control of this play. And it is challenging for him to be able to reference me, look at me, okay, and then produce, okay? So I'm meeting him where he is, and we're in the kitchen, and I'm turning on the water. And in order for me to get his attention, I have to turn the water off and wait for him to either respond in some way. Most of the time, it's a nonverbal way. And if there is some talking, then the talking is often mumbled. Okay, so how do we fix that? So once I'm looking at being able to touch his body, in an earlier part of this video, which you don't see, I actually touched the water and I stroked his legs and I stroked his arms, and you can see he's kind of wet. Okay, and now I'm trying to get towards his face. So here we go. Okay, ready? Oh, you want more. Okay, we're gonna do more. Okay, we're gonna do your rubs. Ready? Let's do your rubs. Ready? 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, in this particular instance, you can see he's like, I don't know about this. You see him look up, he's feeling it. I don't know if I like this, but I'm very slow. I'm rhythmic. I'm counting. I'm singing my numbers, you know, trying to calm his system so he doesn't react in a negative way. And even when he protests, I still continue through with it because we're wanting to make a change, but I'm working on helping him develop a routine so that he becomes familiar with the routine and then is much more accepting. Okay, so that when we get to the point where we're helping the muscles move, that he's able to handle this tactile cue. Okay, and then notice that I went from big muscle group to smaller, smaller, and then here underneath, okay, before I go on top. And the reason for that is because the top area is really sensitive. Okay, so I hit the sensitive or most sensitive part last. Okay. Okay. So one thing I do want to talk a little bit about is the sensory cup. And I am a sensory certified therapist, and I feel like this is very important because OTs do a really great job at being able to regulate our kids. As speech therapists, you know, we're like, oh, that's an OT thing. But sometimes when I'm in a session, I don't have an OT there to help me, but I've got to be able to help my child feel comfortable. So one of the things that I look at is getting the child to feel comfortable. And there are 8 different areas within our sensory system. Now, this is a little bit simplified. It can get a little bit more complicated, but for you parents out there, I just kind of wanted to share this with you. Interoceptive is things that are happening inside the body. So oftentimes if you have digestive issues or you have sleep issues, you know, you are able to remedy that with home remedies. Sometimes you have to have medication in order to help with, you know, so slow flow and things of that nature, which, you know, your body is already working really hard to just function. If there's an increase in pollen, for example, outside, your system is attacked and your musculature is inflamed, your tissues are inflamed. And so that can take a lot of cognitive space, which means that when that happens, you're not free to have cognitive space for more learning. So this is where this cup comes into play. So you have that interoceptive, then you have proprioceptive and vestibular input. Proprioceptive input is kind of like joint compression and extension. So oftentimes when our kids are looking for bouncing input, jumping input, jumping from a high location to a lower location, they're getting that good deep pressure. Vestibular input is swinging or movement. And generally speaking, if you have swinging that happens and you are swinging in one direction, that's very calming. Okay, where a swing in a turn or rotary fashion can be very alerting. So that's why those people who ride roller coasters or thrill seekers, because they're looking for much more input, and that's very alerting. And then we have our normal 5 sensory areas that we learn about in school: taste, smell, what we hear, what we see, what we feel. And then if everything lines up well, then we have behavior. Behavior is both. Okay, if everything lines up great, we have good behavior. If there's a crack in the system, then behavior is not optimal. Okay, so when our children are regulated, then we have good behavior, and then we can attain good eye contact, joint attention, and then they're ready for learning for speech and language. In this particular instance, the reason why I'm going over this is to discuss our emotional input. So I often talk about the upstairs brain. Okay, the upstairs brain is your executive functioning, your reasoning. I can give you directions, you can understand directions, we can have a communication, conversation back and forth to discuss our perspectives. The downstairs brain is your emotional center. And when you have an emotional center, it has to deal with anxiety most of the time. And anxiety meaning that you're not aware or have no idea of what the expectation might be. And so then your child might be a person that elopes, runs away, okay, because I don't know that person and I don't know what they're going to expect from me. They're wearing gloves. The last time I saw somebody wear gloves, they were poking me. So all of this is frightening and I just want to run away. Otherwise, we might have the opposite response where, I'm not going to have it and I'm going to fight you the whole way. Or they just might panic and just freeze. They can't move at all. So you get all three of those responses. And when we're looking at that type of response, either I want to run away or I'm going to fight or I can't move, we look at our sensory system and we say, okay, what can I do therapeutically to help you be able to come down from that anxiety so that I can start working on reasoning with you? Okay, so this is where this sensory cup really comes in handy to be able to understand those components. Okay, so let's talk about prompt assessment. Okay, so one of the first things that we look at is structure. And this is where all of the oral myofascial kinds of things come into play. Whenever we do an assessment, we're like, okay, let's take a look. Is it a muscle-based issue? Is it a structure because the bones are not growing the way that they're supposed to? What kind of effect does that have on obtaining speech and language? Is it going to be instructing, is it going to be impeding the speech production because my tongue is not going to be in the right position? Maybe my tongue is out forward, hanging out forward of my mouth. And then that means that all the contacts that my tongue has to make during chewing exercises or during speech exercises are going to be impacted because my tongue is not in proper alignment or my jaw is not in proper alignment. So these pictures really illustrate what that jaw alignment might be. Oftentimes I have children that are so sensitive orally that it's very difficult for them to go to the dentist. And then there's sedated kinds of things that have to happen, which is okay. Sorry, I was muted for a second. What I'm looking for is good alignment. And what people are not familiar with, generally speaking, is that if your jaw is out of alignment, your posture is going to be out of alignment as well. Our system has, our body has redundant systems, okay? And you'll see those over time. So in this particular picture, I just want to show you that if your jaw is in good alignment, you're going to have a good spinal alignment. If your jaw is forward, that's called a class 3 malocclusion. Okay, then generally speaking, you're going to have part of your spine moving forward and part of your spine moving back. If your jaw is small compared to the maxilla, that's the top portion of your mouth, then you're going to have kyphosis, or that's a humping of the back. Okay, so like that dowager hump. And that's where I often talk about turtle posture with our kids, because they collapse. And when they collapse forward, they collapse the diaphragm also, which means that their ability to project any sound is decreased. And then just looking at the spine in this particular instance, you can see that if there are any kind of compensatory strategies, you might see an asymmetry that's happening with the back. Okay, so you might have a curvature that causes a hip or a shoulder rotation, a head rotation, and then you could possibly have scoliosis. So when we're looking at this structure, it's important to be able to look at what is presented, or the way in which the child is presenting. Okay, and that's going to tell us how well we're going to be able to get that bottom jaw and top jaw together for good occlusion or closing, for open and closed movements, for production of speech. Okay, and so here's a great parent. I love all of my families that I work with. She's just going to talk a little bit about postural control, and I'm going to tell you, I haven't written a paper, but one of these days when I have extra time on my hands, I'm going to write a paper about posture regarding sitting down, having a good foundation. And if you don't have a good foundation, then your jaws are not going to align properly. So in this particular instance, here's a little guy, okay, and you can see that his hips are off. And in order to help him sit, he has to kick out an arm. So he has to use a greater base of support from his hand all the way over. Okay, which means that when he's talking, guess what? That jaw is not going to be in an alignment. It's going to swing one way or another. So now, in understanding that a little bit, then you'll understand why we as speech pathologists are going to look at helping the jaw find the right alignment for good movement. In this particular picture, just some months later, you can see that he does not require his arm to help him sit. And look, his posture is perfect. He's got great posture. So here we'll listen to Mom. Christina, tell me a little bit about posture. What did you learn?
Yeah, so early on, you and I talked about kind of the connection between Deacon or children's posture, especially like leaning to one side or kind of favoring a side, and then the symmetry of their face and how, you know, affects their speech. So we have been working really hard on Deacon about making sure that his posture is correct, that he has that good foundation, especially when he's like playing or doing anything involving his upper body, like rolling out Play-Doh or playing with sensory bins and stuff like that. And also sitting in chairs, that he's not leaning to one side or kind of sitting with one leg up, but that he's got like a good foundation. And now he's made so much progress with his speech. His posture is so much better when he's sitting and playing by himself. I rarely have to correct it. But at nighttime, when he's getting really tired, I've noticed that sometimes after a busy day, he tends to kind of revert back to that sloppier posture where he's favoring one side. And I can see the correlation when he starts doing that with his face. Also, he starts losing some of those improvements that we've made. He starts favoring one side and has lacked the symmetry that he's worked hard to achieve. So as soon as I correct him and I fix the posture, you can immediately see a correlation with his face and how his facial symmetry improves, his pronunciation improves. I mean, like everything, it's just like a domino effect. When we get that posture correct, everything falls in line right behind it. And it's instant whenever we correct it. So it's important.
My parents are great. You know, we've got two little guys. We've got the little guy we're working with, and of course, he's got a little bitty brother that also wants attention. So it's fun that we can address both of those at the same time. But sometimes, you know, kids, they want attention. So in this particular instance, what I want to talk a little bit about is the first part. Okay, so we looked at our skeletal structure, we're looking at posture, how that's affected, and now we're going to look at the muscle tone. Okay, so muscle tone is the ability of the body, okay, to stand up against gravity. So in these particular photos, I just kind of want to show you that this is a resting posture. 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 And what resting posture actually means is that this is the face that you see most of the time. So if we have this little guy, how many of you feel like he's got, you know, high tone? Let me know. Just put it in the chat box. What do you think? Yeah, high tone. Yeah. So if he's in this, we call these high tone kids smiley kids, okay? Because he's smiling and he's super cute. Oh my goodness. All right. But if we're smiling all the time, how easy is it for us to talk? What do you think? Easy or hard? Easy? Okay. So I'm going to cover my mouth. Okay. So you can see me. All right. And then you tell me if this sounds correct. Milk, milk. What do you think? Does that sound good? Not really? Okay. Now watch. Milk, milk. What do you think? Does it look good? No. See, so when we have this high tone, that means that our muscles are super tight, and that reduces the amount of range of motion that our lips have to come together to produce b, p, and then even we get a lot of mama, mama. So we get our teeth and our lip, bottom lip, to work together for some of what our lips, both lips should do, bilabials. We have lip and teeth, mama. Okay, so it sounds okay, but it doesn't look okay. So that means that it's a compensatory strategy. In the next picture, okay, what we see is a little guy that is also a smiley kid. Okay, whoops, sorry. Is also a smiley kiddo. All right, and he has what's called a class 3 malocclusion, which means his jaw comes forward past his top lip or top teeth. So he's smiling and he has this jut. So he has two things he has to do to try and get his lips to come together. Okay, so then he has to work doubly or triply hard. Does that make sense? Okay, in the third picture, this is a little guy with Down syndrome. His jaw is completely relaxed. And to boot, his tongue is forward. Okay, so to try and talk, he has to engage his muscles just to get them to come together. So that's going to be much more work. Same thing with our last little guy, just an open mouth. Okay, but he doesn't have tongue protrusion. So when we're looking at that tone is going to set the stage for how much work we have to do in order for us to get to what we call neutral resting posture. And neutral resting posture is what oral myofascial therapy is all about. Okay, so let's look at the next slide. What is neutral resting posture? Neutral resting posture means that your lips come together gently, okay? And then the medial third, okay? 1, 2, 3, medial, middle third, come together. A nice resting posture. Oftentimes when I'm working with new therapists or new parents, and they're trying to get their children to come to this neutral position, I often get this. If I'm really high tone, our muscles are super contract, and I try and bring them together, my lips disappear, okay, which is still a compensatory strategy. So it's still going to take a lot of work. So we want the muscles just to come together in a nice relaxed fashion. Okay. And then if our lips are together, we're able to produce nasal sounds easily. Okay. The opposite of nasal sounds is our oral sounds. So when we have smiley kids, we have to relax their muscles and then work on their diaphragm. And so here we're starting to add some air components. Okay.
Good. Lips, please.
Okay, so she's really struggling just to bring her lips together. Okay, and then on top of it, to get her air going. Okay, so when we're working on just air, we're working on. When we add voicing, okay, here's our vocal folds. Ah. Okay, those are both oral sounds. When my lips come together, So an easy way to remember the first stage of getting your air and adding voicing together is the word ham. Okay, so okay, see how she does. Okay, so because she's a smiley kid, we're trying to get her muscles to relax. So the opposite of smile is kiss. Okay, if I cannot relax these muscles, then those lips are not going to come together. So I'm going to work on kiss. So oftentimes, in order to help work on that kiss, we might get bubbles or we might get horns, or we might pull the musculature in a nice rounded position so that the lips will come together nicely. Okay.
Oh, nice.
Okay, so now we're putting things together.
Try again.
This is the first time she was able to bring her lips into a neutral position. And then you can see the position is different. And I'm helping pump her tummy like a billows to engage that air. Okay. And now, let's see. So she was able to bring those lips together, and you see her puffing her own cheeks. And so she's able to engage that diaphragm. She's got good posture. She's ready. Okay. So here we go. We do what's called mass practice. Mass practice is working on a particular motor plan to be able to help the brain register these tactile cues to reproduce it constantly, okay, so that it becomes an active production and not a passive production. When you see these kids and they're not producing, this is passive. That means that their brain is registering this input that's happening. Okay, they're not able to coordinate all that air and this muscle input at the same time. It's going to take a little bit of time for that to develop. Okay, so this is really fun.
Okay, this is just a, okay, I want you to feel your tummy right here. Feel? Mm-hmm. Feel your tummy. Okay, ready? Feel your tummy. Mm-hmm. Feel your tummy. Feel your tummy. Feel your tummy and open mouth this time. Yes, good job. Try it again. Okay, feel your tummy and open your jaw. Yes, good for you.
It's pretty exciting to see because right now what he's doing is he is really working hard to feel that diaphragmatic support. Okay, and you can see his body is kind of floppy. So he's a little bit low tone. Okay, so it's taking a lot more to bring that jaw back up because you notice he wants to open that jaw every single time. Okay. Okay, sorry. Okay, sometimes we use some props to help us to be able to better assist the jaw or assist the cheek. And so in this video, this little girl is using a bite block. Okay, and she's learning to produce sound. Okay, but her sound is not coming out orally. So when that happens, okay, she is what we call using bone conduction. So she's making sound, but that sound is happening all inside her bones. So it's very similar to if you were in school and you ever had to occlude your ears so that you could hear yourself study. That's bone conduction, because when you close your ears, your sound is augmented. It's louder, so you can hear yourself think. So she is learning to produce. It's just she hasn't gotten out orally. Okay, so she's producing in bone conduction. So you can see a little bit here.
You said like bite block number 5. Good job. Again. Good job. Again. Good sound.
One more.
So you hear that, that's all resonating here in the cranial cavity instead of out through the oral cavity. Okay. All right.
You said like
Okay.
Good.
Okay, so you'll see sometimes what happens with some of our kids is when they're starting to move their jaw, what happens is that they open their jaw, and we call that, and they open it too wide. Like we call that hyperextension. So they're looking for input here at the TMJ area. Okay, and they're opening and they get stuck. They lock their jaw in an open position. And then you'll see that I'll have to shake to unlodge this a little bit. It's a firm pressure, but not something that's going to hurt the kiddo. It's just to unlock that jaw so that we can have good open close position. So he's starting to coordinate that muscle, and that muscle is the jaw. The mandible is the first big mover. So before we were working on just sound, now we're working on the big mover. Okay, I'm sorry about the crayons, y'all. This is not from my PowerPoint. It's just a little friend, I think, that was enjoying touching the screen. So sorry about that.
Sad.
So he's much better now at coordinating that muscle movement, and he's much clearer. Okay, so then we're going to move to labial facial. Okay, so this is our rounding and our retraction.
Ready? Close. You see that jaw jet forward? See, look right there. It's out of alignment. Okay, right here. Good. Close. Close. Relax your jaw. There you go. Good try.
So in this particular video, you can see that she's just now learning how to move her jaw, and she still doesn't know where it should be in space. So what that means is that her jaw is starting to move, and she opened it wide and then it got locked. And when it got locked, when it came closed, her jaw jutted forward. So that bottom jaw moved over that top jaw. Okay, and so I had to wiggle her jaw to get them back into alignment. And you can see her brain is giving that information, and it's such a powerful message that she's pushing against my hand pretty hard. Okay, and so that's where that support hand in the back of the head is going to be much more helpful to be able to show the brain, give the brain feedback to pull that jaw back into alignment. Okay. All right. So let's look at the next one. It's of the same little girl.
Ready?
But you're going to see a lot of wiggling that happens with the jaw.
You say. Uh-oh. Here, try again. Together. Mom. Good. Mom. Again. Mom. Nice. Okay.
So in this video, you can see she's still trying to figure out where her jaw should be. So the moment that she pulled her jaw up, her cheeks worked so hard that she went into a smile. Okay, so in order to get those lips back into neutral, relax those lips. So I'll give you that video just one more time because it's a very good video to show how difficult it is to go from receiving that information to taking on more control for the production of speech. So we'll look at it just one more time.
Ready? Here. You say. Uh-oh. Here, try again. Together. Mom. Good. Mom. Again. Mom. Nice. Okay. Ready?
So in this particular video, you could see that she is starting to learn where that jaw should be, and she's coordinating her air, and she's getting that air in the mouth and also in the nose for the sound. So she's able to switch from the nasal production to the oral production. So it's really great for her. Now, I'm sorry,
That was
now we're
no.
getting
Can you
to
tell
our
me?
lips.
No.
No.
Good try.
No.
You got it. And then you went no. Oh. Let's try again. Ready? No.
No.
Good try. No.
No.
Good trying. No.
No. I did.
Good trying. Let's try. No.
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 No. There it is. Good job.
Sometimes as therapists, we want your children to talk just as much, if not more, than what you as parents do. And so you saw me, I got a little overzealous and almost poked her eye. Sorry about that. That's my little friend Isabel. And just trying to get her to coordinate the sound with the O sound. So here, this is the nasal telling her produce that sound out of the nose, and then O. So since rounding the lips and retracting the lips is higher on the hierarchy, it's much more challenging. And then what happens is that we often have a segmentation. So that's O, O. So she's not getting no. So she needs that co-articulation. So she's got to elongate that consonant and elongate that vowel. Okay, have a longer duration to be able to make that no pattern. So she still has some work to do. This little girl is talking now, so it takes a little bit of time. We're going to look at the retraction
Do our activity.
component. Okay.
P. Ready? P.
P.
Give me 5.
So it takes a little bit of time, but it does work. So here we go. Now we're going to talk a little bit about the tongue. The tongue has so many different areas, surface areas, the back part of the tongue, the front part of the tongue, and then you have this middle portion of the tongue for our sound. So the back portion is our k, g, ng. It's also the area that elevates for us to swallow. Okay. The tip is our t, d, o. Okay. And then the middle is where you have your ch, j, zh, sh sounds. And those middle sounds are the hardest to get. Okay. And then you have your z, which requires the sides, the lateral margins of your tongue to make contact with the palate. Okay. So in this particular video, we're working on the retraction, that tongue-based retraction, the root of the tongue elevation. Okay.
Ready?
Gub.
Try again.
Gub.
Yes, good for you.
One thing that you have to understand is that when we are first looking at a new target, we're just looking at the muscle target. Because he has a k, g, any of those targets would be correct because it's that motor movement, that elevation of the root of the tongue that we're looking for. So even if he gave me gup or ngup instead of cup, I would still count that as a success because he's elevating the root of the tongue, which is the first portion. And then the other parts we can refine to help him be able to acquire just the k, to disassociate k from g, because both of those sounds have the same movement. Okay. So this is tongue tip elevation here. This is a true child with apraxia speech. And I did see that there was a question that asked if this works for all ages of children. Yes, it does. And does it work with adults? Yes, it does. Okay. So it works with a lot
This
of
right here
different
is the
disorders.
pillow. Okay, so if we're gonna face her, how about we put the pillow and say, wait, put on top,
Pop,
top,
pop,
okay, up,
up,
top,
top,
good try, up,
up.
good top. I'll put that on top, right there. And then there she is right there. And then there is her blanket, see? There we go. She able to sleep on that bed? Yeah, okay. Now we're gonna see if it's gonna be a little bit more tricky for her. Let's see if we can add a new mat. What color would you like? Okay, I want you to feel the L sound. The L is gonna go from the back to the front. Ready? Oh, okay.
Baloo.
Baloo, good try. Baloo. Don't push too hard. Don't push too hard. Okay, now we need a new.
Pillow.
It's a dot. Goes on
On
top.
top.
Yes, you got that time.
So apraxia, true apraxia means that you have inconsistencies that happen. And you see, we were working on top and we got cop and pop. It was really hard for her to raise the top or tip of her tongue, the apex of her tongue to go top. Okay. Okay, so now we're going to look at a little bit more of the other sequenced movements that are necessary and are also targeting the tongue sounds. Okay, so in this particular video, I break down words to smaller segments. Okay, and those smaller segments can either be one sound or it could be a combination. So a vowel consonant or a consonant vowel, or a consonant consonant, which is a blend, and then vowel. Okay, which means that we're tasking the tongue to do more things. Okay.
We're gonna go g,
G,
gru,
grew,
okay, gra,
grow,
no,
ba, ba.
okay, gr.
Grow, wa.
Wait. It's too fast. If you're too fast, then what happens is that your jaw starts wiggle, swiggle all over the place. Okay, that means that you are not controlling your jaw. Okay, so let's try it again. We're gonna go gr,
Say it better. Better.
no, no. I want no.
No,
La.
ba,
I want to hear la.
la, ba,
Bar.
ba.
Okay, so now we're gonna do all the different parts that you need for that word. Okay, are you ready?
Yeah.
Okay, good. So do not wiggle. Okay, we're going to take this step by step. That's why we're stopping at each part, because otherwise your muscles are working too hard. Okay? So we want to make it easier for your muscles to get all of those sounds correctly in the right sequence. Are you ready? And we're going to start with gr,
Go,
no,
la, ba.
much better. Now let's see if we can do all of it. Gra,
La,
no, la,
ba.
nice.
Oh my God. Can
Give
I
me a
get a
high five.
kiss? Mwah.
So cute.
We're gonna go.
Okay, so now we're getting to the point where we're putting so many more demands on the tongue. We're requiring the tongue to hit the back, the front, the middle, all within one word. Okay.
Closer. Hey, that was pretty good. How about this one? Tyrannosaurus Rex. Good trying. Okay, so let me help you. This is your tongue right here. Rex. Yes. Okay, so let's see if we can do it together. Tyrann. Can we go? Open.
Okay, he hyperextended.
Tyrannosaurus. I know so many.
Oh my goodness.
Closer.
Okay, so let's see. Here he is again.
Help, Daddy.
That's the big one.
Help.
Here, look at Miss Rebecca.
Help.
Okay, ready? Are you ready?
Yes.
Tyrannosaurus. Say Tyrann.
I did it.
Okay, now say it all together. Tyrannosaurus. Nice work.
So in this particular instance, I was able to reduce the tactile cue and just give him an auditory cue, and he was able to imitate at that particular moment in time. And I used prosody. Prosody is the cadence, the melody, the sing-song component that goes with talking. It's that stress and relax on different words to help cue him in to breaking down that word so that he was able to put all those pieces together. Okay. Oh. Okay. So just looking at the time, we're doing good. I'm going to give about maybe about 8 to 10 minutes. This is a case study that I'd like to highlight. This is at this time, this little girl was 15, 16 years old when she first came to me. And she's doing great now. So took us a little while to get from that whole sensory understanding, those boundaries, to sitting down, doing a functional task, feeling what those muscles should do, and starting to respond. Okay. So here we go.
¿Otro? Ahora tú sigues. Ajá. Aquí. ¿Tú sigues? Abre la boca. Oh, qué bien, mija. Okay, ahora. Oh, no, let's do first. Tú sigues. ¿Dónde fue su voz? Aquí, apréndalo. Prueba el otro. Tú. Qué bien, M5. Soft. El 3-0. Tócalo. Alejandra. Ah. Aprende su voz. Ah. Try. Okay. Aquí. El último. El último. Ah. Abre la boca. Aprende su voz. Qué bien. Ok. Ahora. M. Labios juntos. No juntos. Mira, mija. Qué bien. Ok. Tú sigues. Tú sigues. Ok, ahora tú sigues. Labios juntos. No, juntos. Juntos. Cierra la boca. Juntos. Ok. Dos más.
Poor thing. She has allergies. Remember, we were talking about that interoceptive? All of a sudden, we're breaking down. We have to build right back up because her tissues are inflamed. And so that takes priority over all of the cognitive tasks that we're asking her to do. Okay, so here we go. So now you see that I was giving her some tactile cues, and now she's starting to watch and she's starting to initiate.
¿Puedes? ¿Otra vez? A ver, más.
Allergies.
Mira. Claro. Okay. ¿Lo ves?
Okay, so in this particular instance, you can see she's a smart kid and she's having difficulty pulling her lips over her teeth. And remember, we were talking about structure. Her tongue is often pushing against those front teeth, and so those front teeth have pushed out. That means that the lips have got to do much more work to come down and meet. She now is in Invisalign and she's got great teeth and her lips come together beautifully. Okay. So we'll move on to this portion.
Look down. Watch what you're doing. Dip and okay, look. What is it? It's a red bunny. And what does it do? Let's try it. I want to hear red. Red bunny. Whoa! Nice work, Ale.
And this is just Ali's dad. I love my parents.
Hi, my name is Tony. I would like to share our experience of our daughter with Rebecca at Walking Time. Ali is 16 years old, has been in public schools for several years, little or no progress on her speech development. I was able to attend a conference with families with special needs. There, I heard Rebecca present her services on speech and language development. Her explanations showed how speech and language could be stimulated by training facial muscles. We decided to schedule an evaluation, and the diagnosis showed symptoms of apraxia and poor motor speech articulation. The training plan was started, and Ali had muscle training using feeding and prompting techniques. Soon after, she started to produce sounds on a regular basis. After several months, Ali's visual contact and attention grew significantly. Her capability to produce sounds increased from hum to letters to words. Not only had that, Alice's comprehension of her surroundings increased, demonstrating how she was aware of activities around her. As a family, we were amazed with Ale and very grateful with Rebecca and her team's work. We believe one of the main reasons Ale progressed so much is due to Rebecca and her team believing in Ale's potential. On one occasion, Rebecca described herself to my wife as a problem solver, but we think she's more than that. Rebecca is passionate about her work, and that's what makes her stand out. Thank you very much for allowing me to share our story, and God bless.
So we're coming to the end. And if you want to know, what does it mean to become a certified person? It's a lot of work. So I've had many courses and many mentors in prompt, and that's how long it took me to become prompt certified. So I'm actually the only prompt certified clinician in the DFW area, but my lead clinician is also working on her certification, and I couldn't be happier to help support her in her journey as well. So here are some recommendations for different activities. Once we pick particular targets to work on, we'll pull out activities to help the children be able to acquire those motor skills that they need. And that's it. So I'm going to open it up to any questions that you might have. Anybody? Let me take a look, the chat.
Rebecca, what we're going to do, the chat, we have some really good questions.
Great.
One that came was, would this work with older kids? And I think you did answer that with the last client that you had. Any age, adults as well, right?
Actually, I will tell you,
Mhm.
I have a 76-year-old man who had a stroke and had paralysis on one side. So we call that Bell's palsy. And we've been using prompt to help him recover some of those skills. So it really works with the age span. Okay. And it works for individuals that are on the autism spectrum, that are nonverbal, or people that are on the autism spectrum that are verbal but have limited range of motion. For people that have Down syndrome, cerebral palsy, the last little girl had a concomitant issue, autism and cerebral palsy. And then, you know, it just works with all age groups. You know, some age groups I think are a little bit more challenging than others, especially if they're little and they're very much about controlling their situation. You know, they're a little less or more reserved, shall I say. They're more resistant, okay, to having those tactile cues. And that's why I wanted to make sure to address sensory, the sensory integration component, since it is tactile. And also I wanted to address the touch factor and working from the body up to the face so that we can start working those muscles here. And we have redundant systems again.
Yeah.
You know, it's looking at that posture. If that posture is off, that means that jaw is going to be off. So we really want to make sure to look at the whole person and see what skills they're coming with and be able to look at where we should start with therapy based on what they're showing us.
Okay. So there's a question about, for a child that's using an AT device, how would you suggest incorporating prompt? You did show us with that girl with the 15-year-old, but maybe you can expand on that.
Well, that's a good question. We actually use a lot of augmentative communication. And I recommend augmentative communication for many reasons. When we're looking at that scale, oftentimes we have a lot of understanding, cognition, okay, where the physical sensory, that ability to coordinate all those muscle movements are off, right? And so that scale is like, ooh, I got a lot here, right? But not enough here to balance that system out. And so when we're looking at that, what we really want to do is even it out. And we do so using several different strategies. So sometimes that involves prompt, sometimes it involves some other disciplines or specialties, which is one of the reasons why I have so many, is because I've been trying to figure out, what works for a particular child may not work for another child.
So there's a question about how do you help a child improve eye contact? Is this something that you work on?
Yes. So eye contact. So again, reciprocity has to do a lot with that eye contact. If I don't get that eye contact, it could be because visually it's overwhelming. But what's amazing, especially with individuals on the autism spectrum, is they have really wide peripheral vision. So they may not be looking at you, but they can see you. Easy peasy lemon squeezy. Okay. And if they can see me out here and they're not making direct eye contact, that's okay. Because if looking at me causes them to freeze and they don't have that range of motion because it's taking all that energy, okay, to look at me, I don't have to have them look at me. I might actually work in front of a mirror and they may feel more comfortable looking at me this way instead of face to face. And I'm okay with that. And in the same respect, I can use their Proloquo, their lamp, their Dynavox, and we can work on this is hard. Okay.
Okay. My next question here is, do you suggest getting adjustment, I guess it's chiropractor, done for the kid to help them with prompt therapy?
Think about this. If your child doesn't tolerate touch, okay, if you take them to the chiropractor is going to touch their body. Okay. And when the chiropractor is able to adjust them, because there's some wonderful body workers out there, then that does help them to get that input and puts them into alignment to get those jaws where they're supposed to be. So I would recommend body work. You can do that with a chiropractor. You can go to a physical therapist. You can go to an occupational therapist that is a sensory processing occupational therapist.
Okay. Going down, just a quick question. Does all ASD kids benefit from prompt therapy? My daughter's speech therapist hasn't examined her mouth alignment and all at all. I'm not sure if I need to see another SLP.
So all SLPs have different specialties. Okay. So not all SLPs are going to be trained in everything that your child needs. So if you feel that your child might have a restriction, a lingual restriction, or maybe labial restriction, that's called oral myofascial work, which is something that we do at my clinic, walkies talkies. But if your speech pathologist does not do that kind of assessment, look for somebody that does. They may be able to help you by referring you to another person that has more experience in that area. And I did see something about soft foods. Soft foods are often an indicator that there's a problem with structure. Okay. Soft foods are like the bane of our society as a whole. Okay. Oftentimes we have children that are eating out of pouches. Okay. I get it. I'm a mom too. And it's easy, you feed your child on the go. But those pouches, they push on the palate because they've got a hard pipette that the children are sucking out of. And when they do, that sucking pattern, okay, promotes a tongue thrust, which is an immature swallow, which means it's harder for us to get that tongue back into the mouth and get those jaws closed. Okay. So when that happens and we're drinking like this, that hard piece of plastic pushes up against the palate, and it causes the palate to go from a nice U shape where the tongue can fit against it to a V shape. And then all of a sudden, the tongue can't reach the top anymore. Okay. And so this is something that you can help remedy by removing that and having them work on spoon skills, which brings those lips together for p, b. Okay, so soft foods often indicate that there's a structural issue. Okay, and so remember, structural issues are the foundation of where the muscles lie on top of the bone. So we might have to involve maybe a dentist or an orthodontist, which I know can be tricky with special needs kids, but it can be done because I do work with a lot of different providers. And so we work on a lot of stuff in the mouth to desensitize the mouth. And for me, I often go to dental appointments because I can help soothe the child so that the dentist can get in and do the work that he or she needs to do. Okay, is that helpful?
Yes.
Okay.
There's a question from our wonderful BCBA. She's asking for a BCBA, is there a way we can incorporate this within the session? Can we get this training without being an SLP? How would you recommend we support the children if they are receiving prompt therapy?
That's a very good question. Prompt is specific to speech pathologists. So unfortunately, it's not open to occupational therapists, BCBAs, ABAs, RBTs, or even physical therapists. It's a specific to speech pathologists. However, I work with a lot of BCBAs, ABA therapists, RBTs, and I often give workshops to be able to help them understand the hierarchy of development. And also, I treat them the way that I do parents. I give them the same kind of information that I give parents to help with some carryover. Now, the refined movements, I don't provide that component because then I'm actually assessing a great deal. And that's just the difference of our professions. BCBAs are more into task analysis for behaviors, where speech pathologists, we also do task analysis, but we're assessing all the time. Every single time we give a parameter prompt, what did they do? Were they able to smoothly open the jaw and close the jaw, or did they hyperextend the jaw and lock that TMJ? And do you have the anatomy and physiology to help you to be able to safely unlock that and close the jaw? It's just a difference of profession, and that's why. But in the same respect, if we're working close together, then I can tell you, yes, this is a pattern that I've seen, and this is what we do to help elicit a better motor plan. So working hand in hand with people that have those children for a longer period of time is very beneficial. because I at most have an hour.
Mhm. There's a question whether this works for children that are nonverbal or children who make some sounds, and I think you've answered that. That works for all children, even those that don't make any sounds.
Mhm.
Okay, there's a question about how to encourage a child who likes to do things physically, meaning instead of communicating, wants to do things independently. How do you encourage them to communicate?
Okay, so I'm going to ask a question to understand that question a little bit more. When I hear physically, does that mean that your child uses a lot of body-based communication? Are they a manhandler where they grab you by the hand and they pull you to the kitchen and then they stand you in front of the refrigerator and you're supposed to know what they want?
It seems the question says, go and drag a chair to pick up cereal box from a shelf, then requesting for assistance. He wants to physically get it himself.
Well, then, that's great because he's independent, but at some point he needs you. And guess what? When he needs you, be there. Just like I was for the little guy that was at the sink. He didn't want to work with me. He didn't want to work with me. All he wanted to do was play with the water. He wanted to watch the waterfall. He wanted to fill the cup. He wanted to pour the cup. He didn't want to have any interaction with me. And the only interaction that I could have was by shutting off the water. And then all of a sudden he's like, wait a minute, that's not what I wanted. And then he's looking at me and going, you're in trouble because that's not what I wanted. Basically is what he's telling me. And I'm listening to him and I'm like, oh, did you want the water on? Ah. And so I'm modeling visually because I can't get to him tactilely yet. Okay. So I'm honoring his ability to recognize me as a communication partner. Okay. And that is very, very crucial because it sets the foundation of our relationship, our rapport building. Because remember, he's got to make space for me. Because guess what? Mom or dad are going to be able to know what he wants. And most of the time we'll give in because that's your routine. I'm upsetting the routine because I need a little bit of space to make the change that you're asking me to do. Is that helpful?
Mm-hmm. There's a question about facial expression. How can we know what facial expression can be done, and can a parent figure that out? I think that's the question.
Facial expression. There are so many muscles of the face that have to coordinate in order to demonstrate facial expression. You can have a smile, but have you seen people smile, but their eyes don't smile? Or they could have a frown, right? And then you're looking at them like, are you sad? And they're like, no, I'm concentrating. And you're like, okay, that's a little nebulous. So facial expressions are really challenging. But to children over time, especially if you work in a mirror, can learn to identify some of those things and then imitate. And then they learn to imitate. It means that they're becoming not a passive learner, but an active learner, which means that their awareness is turned on.
For a child older than 21, is it too late to work on posture, sitting, and walking?
No. I actually presented about prompt a few years ago. This is how I had met Alejandra, but I met a little guy. I call him a little guy. Actually, he's having a birthday. He's going to be 34 on Monday. And I started working with him when he was about 29 years old. And what was really amazing is that he needed a lot of work in the mouth, more oral myofascial work, but then also worked on outside the mouth and language, and then got him to a point where we were working on reading and writing. And now he's amazing because he can read, and that makes actual bedtime routines nice because he and mom can read a book together. And he's actually learned how to read script, which is amazing. So I had to buy him a shirt that said, "I am amazing."
So what is an easy way to help my 4-year-old son to use a cup when he drinks? He's having difficulty.
So cup drinking is great. Do you know in the olden days when a baby turned 6 months old, that was the first gift that was given, a little silver cup? And we've really kind of diverged a lot from that because we have sippy cups and we have straw cups, and all of that changes the oral musculature, which means that it changes the structure and it changes the way in which those components come together for talking. And so then we have a lot more issues going on with sleeping and breathing and so on and so forth. But coming back to cup drinking works so many different things, okay? But you have to be patient with the child and expect spills to happen. Working from a cup, you can have a cup, a small cup, okay, and only put a small amount of liquid in there. So if they do spill it, it's not a big deal to clean up. It's easy to strip off a bib or strip off a shirt and then put another one on. Part of that is learning that gravity and how far to go, how to gauge that liquid coming to you. That's hand-eye coordination. Okay. And it's okay. It's okay. Things might get a little bit messy, but if you're okay with messy, and as long as you make it fun and you're at the table, you show your child where they are able to have that apple juice, that milk, that water, whatever you'd like them to drink from a cup is great. And if you give them just a little bit, guess what? They've got to ask for more. And so you give them a natural opportunity to request verbally.
Okay, there's a question that came via text. I'm wondering if the child has A-shaped or narrow roof of mouth, how does that affect speech, especially those need the tongue to touch the roof of mouth, arch expander, and dentistry need to be involved?
Yes. I'm going to show you something. I'm going to show you my tongue. My tongue is too big for my mouth, or actually my teeth, my jaws are too small for my tongue. Okay, so my tongue is scalloped. You see the dentition on my tongue? Okay, I've had braces twice as an adult. Okay, and now I have permanent retainers cemented on the top arch and the lower arch. Okay, so what I should have had was expansion and then had my teeth pulled down. So if I had expansion, that means that my palate would have been nice and U-shaped instead of V-shaped and cupped. Okay, because what happens is that our palate is the lock and our tongue is the key, and they should make contact, and you should have contact from tip to root. That's normal resting posture. When you have a tongue tie, for example, it pulls the tongue down away, and that means that there's no oppositional force to show where that palate should be. Okay, and that's what causes that V shape. Okay, and then if the tongue is down and low in the mouth, then guess what's catching all the debris? Your tonsils and your adenoids. And then you're going to have to go to an ENT if your tonsils and adenoids get too big and they start closing off the airway. And when that happens, are you going to have enough air for talking? No. So structure is a big deal. And a lot of times people don't know, but orthodonture has changed where they have different phases. And generally speaking, in phase 1, they do pre-orthodonture. And if you catch it early between the ages of 4, 5, and 6, you can grow the palate at the same time that the face is growing, which means that it will take less time to be able to fix all of those arches when those palates start to fuse together, and then you've got bone on bone, and then you're looking at surgical procedures. Old orthodonture started at 8, 9 years of age. That's too late in some cases, okay? You want to start as early as possible. And there are some great dentists, especially here in the DFW area, orthodontists in the DFW area, that can help with palate expansion, okay? And oftentimes you just need a little device to help work on chewing. Guess what? If your child chews, okay, you're supposed to chew your food 25 times. If your child chews, then you're going to grow this bone down and forward like it's supposed to. And guess what? This bone is supposed to grow down and forward as well, okay, to get that good occlusion or closed position so that your teeth meet, so that your tongue can rest against the palate, the entire tongue, not just a portion of the tongue. Okay, helpful?
So she also asks functional myology or orofacial myology.
Mhm.
Is that the same as what you were describing?
Yes, it is. Mhm.
Okay.
So this is where prompt is a little bit different. It talks about structure, but it doesn't go into detail about structure. Orofacial myology gives you the detail that you need to look at the structure. So that's why I have both certifications.
Okay. Sensory is a big challenge for my son. If OT isn't helping much, how can he adapt touch around his mouth with prompt therapy?
It's a good question. So I do a lot of sensory. I'm sensory integrated certified as well, because a lot of our kids have aversions. So you're going to know your child, and you're going to know if your child likes to jump. They're going to jump on the couch. They're going to jump on the bed. They're going to walk along the back of the couch. You know, they're going to jump from a higher place to a lower place. They're going to climb up in the closet and then jump down. We have a lot of those different kinds of issues. So in order for their bodies to receive the input that they need to help them regulate and gain attention, they are seeking that kind of input. And sometimes for us, we require some of that input prior to getting to this portion. So it just depends on your child. We have a lot of kids that require sensory, and those that are on the spectrum, those that are not on the spectrum. We all have sensory aversions. Okay.
A mom is asking about, is there any kind of course training available for parents who want to help their kids at home dealing with speech delay, any kind of speech therapy, but not limited to prompt therapy?
There are plenty of courses out there for parents. All you have to do is look at whatever it is that you're interested in. They often have listservs for therapists that are trained or certified, or whatever level they might be at, level 1, level 2, level 3, certified, what have you. And they'll tell you if they're in your area. You can contact that person, you can ask them specifically, and then look for parent groups, because oftentimes there are a lot of parent groups that can offer information for particular kinds of therapy if you're looking for something specific. But yeah, there's feeding, there's motor speech, there's, Even if you go to the Star Institute in Colorado, they've got parent classes.
Yeah, there's a couple of videos that we've done with speech therapists also that we can share with you. You might find that helpful. The one last question, I think, and Blaine wants to share something, I think, about prompt therapy and how it has helped her son. For a child that has low tone with the tongue partially protruding past the teeth, do you have any exercise we can do to help our kids at home?
So again, that's that low tone that we're looking at for our kiddos, because we had our smiley kiddos and we had our low tone kiddos. Low tone kiddos, they need input, and they need input on the molars. So chew, 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 chew. And if they have difficulty with food, you always have chewy tubes that you can order, or chulery that you can order to help facilitate that movement. Because if you push down on the jaw, guess what the jaw wants to do? It wants to push against you. Okay. The stimulus is the push down that's going to want to push back up. Okay. So if you have a child with low tone, they need that chew, 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 chew. Beckman has some great chewy tubes. She's got a Tri-Chew. You can get, it's a 3-piece Tri-Chew with little nubs on each part. And you put that in, it's got different textures. Okay, you could do, Talk Tools have these yellow chewy tubes, the red chewy tubes. You put 2 in, yang, 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 yang. That works on getting that tongue in a retracted position, and it helps the jaws to work. So all of a sudden you're getting those lips, those jaws together, and that tongue is back where it's supposed to be instead of forward and hanging out of the mouth. So there's a lot of different exercises that can be done, and they can be done with feeding. That's why feeding protocols work really well to help with speech protocols, because you require those same or similar movements. A Z-Vibe, I saw that. Yes, a Z-Vibe works well for children that can handle vibration. Children that are looking for vibration are often looking for proprioceptive input, especially if they want to bite down here centrally. Okay, or they put it here at the TMJ joint. Okay, so what I like to do if I have a Z-Vibe is, instead of putting it at the TMJ, I put it along the jawline. Okay, here I have a pencil. Okay, I put it along the jawline because that's giving proprioceptive input here. And I'll count to 5. I'll do here. I'll count to 5. I'm going to go lower lip, count to 5. And then last but not least is the top lip, because that's really sensitive. And guess what? I'm going to tickle. That's going to tickle me. And I'm going to go, whoa, that's too much input. Okay. And move away from that. Does that make sense? Okay, so Z-Vibes work well. The only caveat is if there are any seizure disorders that go along with that, then you have to be extremely careful with vibration.
Thank you so much. This has been so helpful. We've learned so much. We're going to let Belen tell us a little bit about her experience with prompt therapy. Belen, are you here? Can you unmute?
Yes, I had to switch phone, sorry. So
Cookie's phone?
I had to switch, sorry guys.
That's
so okay. Tespi has been going to Miss Becca actually for 2.5 years now, and he was completely nonverbal when he went to her. I think she's very cautious to share him because he's in this community. But Miss Becca, I'm very open. He's her poster child, actually. She's made 1 million changes with him. And not only him, actually, my sister's daughter who has Down syndrome has also worked with Miss Becca a couple summers. And she caught her scoliosis, and she's found different ways to treat her. Same with Tesfi. And if you guys remember, whenever I did my presentation, I said, you work at home, that's Miss Becca teaching. I strongly encourage everybody who is able to see Miss Becca to see her. She really educates every single session and teaches me what to do at home regularly. And that has made a difference. He went completely from not saying a single word to almost conversational. And now she's working even on the S sound and all that with him, like, which is a much higher level of speech. For feeding, same thing. He was very intolerant of so many textures, and Miss Becca has actually helped him come. So, I mean, she is able to completely explain, even if English is hard to understand, she does show you. It's something you can touch and do. And በአማርኛ ትንሽ ልናገርና በጣም በሌላም በኩል ትረዳችኋለች በመንካት አንደርስታንድ ማድረግ የለባችሁም እንግሊዘኛውን ለእሷ የምታስረዳውን እንዲገባችሁ ኢች ሴሽን ላይ እያንዳንዱን ትሬኒንግ ትሰጣለች ምን ቱል እንደሚያስፈልግ ታስረዳለች ፕላስ እቤት ሄዳችሁ ምን አይነት ኤክሰርሳይዝ መስራት እንዳለባችሁ እና I really would love Miss Becca, you can tell him the big change Tesfi has made. I think this will motivate everybody to look into prompt speech.
He's, you know, I love all of my parents, and Glenn is amazing. And if you noticed, in every single session that I showed you, my parents were always in the session. It's because I can't do it alone. I need you. We are a team, okay? And I don't get to see your child as long as you do throughout the duration of the day or the duration of the week. So we have to work together. And that's why I work so hard with training parents to help them be able to follow through and carry over all of the tasks that we present during the therapy session. So the therapy session can be therapy and showing, or it could be education. And oftentimes it's a balance between the two, especially if we're moving from one skill level to another skill level, we're going to expect pushback. And the reason being is because change is hard. And we appreciate those more challenging sessions because we learn to work through that frustration. We will learn to work through and go and know that you're going to be okay. One of the things that I often say to my patients is, this is hard, but I can do it. This is hard, but I can do it. I'm all about that motivation, internal motivation for the child. Right now, our children are very fast-paced and they have a lot of external motivation, very little awareness of internal motivation. And we slowly work through that so that they find the motivation to tell you what they feel and what they think. And Tesfi is really quite amazing because I can tell you that I have video footage from when he first started. And the one first video that I don't have, which I really regret, is singing about colors and pulling out scarves of different colors and identifying them. And he's running around circles around me. And I'm like running after him going, okay, because our attention span was really, really limited. Okay, he was very sensory oriented as well. So that running was really good, especially when you could run and you could hit the wall, and then you can run, you can hit the other wall. And in between, we're doing peekaboo and colors and things like that. And now he can tell me, oh, it's just Miss Becca. Oh, Miss Becca. And he tells me my age, which I won't share with you. And it's really quite funny because he's developed this sense of humor that has just been a delight to know. So in 2.5 years, he's gone from nonverbal to carrying on conversations. It's amazing to see.
Okay, Becca, we appreciate you so much. There's some question about, as I told you, many of the participants are not in the DFW area. They're asking for recommendation in several cities. I think the Prompt Institute has a website where they can search for prompt certified speech and language pathologist. Do you have any recommendation or anybody you've worked with? Please let us know. Other than that, I think this is going to be the end of our your presentation. We really appreciate you, and but this has been so informative and very helpful. Hopefully you're going to come and visit with us again.
Thank you.
Bye-bye.
Bye-bye.